Systemic sclerosis. It's a systemic disease of unknown etiology characterized by skin thickening, hardening, scleroderma, and by a specific organ involvement, lungs, GI, heart, kidney. Scleroderma is the characterizing and differentiating factor with respect to other connective tissue diseases. There are four different forms of scleroderma. We have systemic sclerosis with diffuse scleroderma, where we have a rapid skin thickening in distal extremities, proximal limbs, face and trunk, and an increased risk for kidney and visceral involvement. We have also a second type, which is systemic sclerosis with limited localized scleroderma, where we have a symmetrical skin thickening localized to distal extremities, face. We have a better prognosis, limited internal organ involvement, and we have also CREST, associated with CREST, which is a syndrome where we have an increased risk for biliary cirrhosis and pulmonary hypertension. A third form is systemic sclerosis scleroderma. It's without skin involvement, so we have only serological vascular manifestations and altered internal organs. And then we have intermediate forms like UCTD and MCTD, which is associated with SLE, systemic sclerosis, polymyositis, rheumatoid arthritis plus high titer anti-RNP. So this is associated with sclerodermal-like skin findings. They're just skin disorders, these ones, and they don't have any potential for internal organ involvement. We have morphia, linear scleroderma, coupe de sabre, hemifacial atrophy, scleromyxedema, nephrogenic fibrosing syndrome, which is a rare and serious syndrome that involves fibrosis of skin, joint size, and internal organs. We can also have chronic graft versus host disease, eosinophilic fasciitis, eosinophilia myalgia syndrome, and chemical-induced scleroderma, or paraneoplastic syndrome. Epidemiology, it's a rare disease, incidence in 19 cases per million per year, prevalence of 286 cases per million. Females are much more affected than males, as usually in these autoimmune diseases, and age of onset is between 30 and 50 years. Black are more affected than Caucasians, so we have an earlier age of onset. Genetics, we have concordance between monozygotic twins, 4.7%. The correlation between relatives is 1.6%. We have a high prevalence in certain ethnic groups, such as Native Americans. Increase the relative risk of having a second connective tissue, SLE or RA. Another factor is association with a number of polymorphisms, ACE, AT1, NOS, CD19, MPC, NCP1, IL-1 alpha, IL-4, TNF alpha, C, TGF, TGF beta, fibronectin, fibrillin. A number of people from New York were affected by scleroderma following the 9/11 attacks on the World Trade Center, probably as a result of silica or asbestos being released. Also miners, chemical industry workers, and people who consumed tryptophan-based preparations have been associated with scleroderma. Pathogenesis is something unknown causes tissue damage, thus activating the endothelium and recruiting lymphocytes and fibroblasts. This recruitment of cells will cause mononuclear cells to start producing IL-1 and TGF-beta, which are potent fibrosing factors. Then there is probably a Th2 response with further production of TGF-beta that further sustains the production of collagen by fibroblasts and also the maturation of B cells to plasma cells, which is why these patients have hypergammaglobulinemia. If you take biopsy from the skin of a scleroderma patient, the fibroblasts will start to grow, and once they reach the border of the culture plate, They will not stop growing, but instead keep secreting collagen without any control, neoplastic behavior without being neoplastic, therefore. Pathological aspects are fibrosis, vascular changes, and telangiectasia in the skin and immunological alterations. Vascular changes are Raynaud's phenomenon. Patients with scleroderma also have Raynaud's phenomenon in the internal organs. Cold and nervous stress may induce this. And we have microvascular alterations, so we have an arterial or intimal proliferation, deposition of collagen subendothelial, and microthrombosis, narrowing of the lumen. Natural history is the disease has two phases. We have an edematous phase and a collagen phase. In the edematous phase, there are inflammatory changes in the skin accompanied by inflammatory indices in the blood tests. The appearance of the skin is edematous and the fingers are puffy. This phase may last for a long period of time. The prognosis of the disease as well is better as this phase is longer. The edematous phase is the only phase where you can have some kind of response to the anti-inflammatory treatment or immunosuppressive treatment, because this is where you have the inflammatory cells. You have the collagen phase, that is also known as atrophic phase, where fibroblasts are producing factors and collagen is being deposited. This deposition is associated with physical alterations of the skin. It takes away all the physical characteristics. All the superficial skin is lost, and the remaining skin is smooth except for the mouth region where wrinkles are present. The patient has extreme difficulty in opening the mouth because there is a huge deposition of collagen there. As the disease progresses, the patient might end up not being able to move their hands because the skin has become so hardened that it prevents the movement. These patients will experience myopathy and arthropathy due to the misuse of the hands. This leads also to bone resorption, so always due to lack of activity. Changes in the vascularity may lead to gangrene and very painful lesions that can get infected. This makes it difficult to treat as it is poorly vascularized. You must perform a correct surgical cleaning, restore vascularity, or use vasodilators. Organ involvement, we have in the two main forms of scleroderma, Raynaud's phenomenon is always present. So it's present in virtually every scleroderma patient. You have to consider systemic sclerosis when you make the differential diagnosis of Raynaud's phenomenon. So we have musculoskeletal involvement, pain, swelling, and stiffness in the fingers early. Polymyalgia or symmetric polyarthritis in the diffuse form. Advanced forms, we have reduced more mobility due to skin fibrosis. We can have also disease myopathy, where we have normal muscular enzymes. We have 5% mild myositis overlap with polymyositis and systemic sclerosis. We have GI involvement, where we have dysmotility. At the early phases, we have vascular spasms, ischemia, and damage to nerve fibers. Then we have muscular atrophy and wall fibrosis, up to overt malabsorption. We have in the esophagus, it's involved in 90% of patients. We have reflux esophagitis, so that we have a reduced lower esophageal sphincter tone and distal esophageal distension. We have a possible Barrett esophagus. Dysphagia is modest, normal pharynx motility. We can have at manometry, we see a decrease or disappearance of peristaltic waves in the 2/3 lower esophagus because of smooth muscle involvement. There is myofibroblast involvement. Polymyositis involves the proximal esophagus and the striated muscle. The collagen deposition can go on also in the small intestine and the colon. In the small intestine, we have asymptomatic dysmotility. We have chronic pseudo-obstruction, we have abdominal pain, distension, and vomiting, and we have malabsorption, bacterial overgrowth. We have also diarrhea, weight loss, and malnutrition. In the colon, we have constipation, whole muscular atrophy, transverse and descending colon in diverticula. Lung involvement, We have pulmonary interstitial fibrosis, frequently asymptomatic up to late disease. It's a major determinant of morbidity mortality. Clinical manifestations are dyspnea on exertion, dry cough, Velcro-like crackles. Cutaneous sclerosis is not in proportion with the extent of fibrosis. You can have a patient with normal or very limited skin involvement, but with a huge pulmonary manifestation. We have a more severe fibrosis in patients with diffuse form where anti-scleroderma 70 positive. Possible epigestis pneumonia also can be present due to esophageal atonia. Diagnosis can be made on a chest X-ray, where we have opacification of the lower two-thirds, which is specific. We have can use tests like RFT and DLCO, HR high resolution CT of the chest, and bronchoalveolar aspiration and lavage. Where we see an increased cellularity in the inflammatory stage of the disease, alveolar macrophages, lymphocytes, neutrophils. It's non-specific but useful for evaluating the severity of the alveolitis. When you enter the fibrosing stage of the disease, you will not find inflammatory cells. Another important aspect of lung involvement is lung fibrosis. It can be secondary due to fibrosis distorting the lung parenchyma and obstructing blood flow, or primary, as in CREST syndrome. We have a kidney involvement, so we have a scleroderma, renal crisis, 10-20% of patients within 4 years from onset. We have accelerated arterial hypertension, we have a rapidly progressive renal failure. Looking at the image on the right, how would you treat a patient with such a vicious cycle? With ACE inhibitors. So in case of case of kidney involvement, we use ACE inhibitors. We have a cardiac involvement, so conduction disturbances, fibrosis, ischemia of the conduction system. We have myocardial disease, hypoperfusion, coronary vasospasm, cardiac fibrosis, which is a consequence of systemic or pulmonary hypertension, and we have pericardiac disease. So just to see again, in limited systemic sclerosis, we have prevalence of esophageal involvement and pulmonary arterial hypertension, among with the other manifestations of CREST syndrome. The diffuse, we have also organ involvement and every kind of involvement. So we were seeing the various manifestations of scleroderma. We have skin involvement, myopathy due to this motility caused by scleroderma itself, GI involvement with reduction of motility and bacterial overgrowth, resulting in malabsorption, which is almost invariably present. We have pulmonary interstitiopathy with fibrosis. It has to be a primary lung disease of the arterial system of the lung, and kidney involvement, scleroderma renal crisis prevented by ACE inhibitors. So eventually we talk about cardiac involvement in scleroderma. Since scleroderma is a fibrosis disease, most frequently you have conduction disturbances and myocardial diseases due to the connective tissue that is synthesized there, resulting in a reduction in contractility and problems in ventricular diastolic function. You may also have pericardial disease, which is again in line with the fibrosis disease. You may also have a number of other rheumatologic involvements that are actually due to the fact that a thickening and hardening skin will determine problems of the underlying organs, but also you will have fibrosis of the different structures. So, this is a general scleroderma. This is in general scleroderma. However, there are two extreme forms. One called diffuse scleroderma, in which every organ may be involved, and a more limited form that involves fewer organs. One of the limited forms is the so-called CREST syndrome. CREST stands for calcinosis, which are calcific deposits in particular locations in site of repetitive trauma, can drain through spontaneous fistulas. We have Raynaud's phenomenon, sometimes year before other symptoms, esophagopathy, so lower sphincter hypotonia early, sclerodactyly, fibrotic changes limited to the fingers, telangiectasia, due to aberrant neovascularization, gradual increase over the years, in the diffuse form only later. Patients are to be monitored for the onset of pulmonary hypertension, and we have also association with anticentromere antibodies in 80% of cases. There are a few lab studies that may help in diagnosing the disease. Indeed, they are often completely normal, specifically in the limited forms, and keep in mind that the systemic inflammation does not correlate with the severity of organ damage. So there is no correlation between inflammatory indexes and organ damage. You may have an increase in the inflammatory index, such as ESR and CRP, but they typically are high just in the early phase. Remember that we have an early phase which is inflammatory in nature, and then we have a more chronic atrophic phase later. Also, you will have anemia of chronic disease, or also iron deficiency anemia due to GI bleedings. Megaloblastic, loss of B12 and folate due to bacterial growth in the small intestine, hemolytic microangiopathy, kidney involvement. What you also detect are autoantibodies. Virtually all patients with scleroderma have antinuclear antibodies. These antibodies, they recognize two major determinants: scleroderma 70, that is topoisomerase 1, the antigen which is typically associated with the diffuse form of the disease. Patients with limited form instead, specifically present with CREST syndrome, will have which specifically present patients with CREST syndrome will have autoantibodies able to bind to centromere. So the antibodies can be autoantibodies can be antinuclear antibodies with IF immunofluorescent pattern, can be nuclear speckled in the diffuse form, or anticentromere in the crest, or other limited forms. Antitopoisomerase 1 antibodies that are anti-scleroderma 70, 40% of cases they are NORGO, nuclear organizer region, anti-RNA polymerase 1 and 3, diffuse form in association with renal and heart involvement, anti-U3-RNMP, fibrillary in 5% of patients, anti-PM-SCL, which is where we have an overlap with polymyositis, dermatomyositis. We have anticentromere antibodies present in the limited cutaneous form or CREST, and 10% of patients with the diffuse form. If present together with Raynaud's, it predicts the development of cutaneous limited form. We have also anti-Rho SSA sometimes. This is again to show you the frequency of the various manifestations in this table. So, the American Rheumatological Association developed a set of criteria to classify scleroderma and scleroderma-like disease. You have one major criterion and two minor criteria. The major criterion is proximal scleroderma, that is extension of fibrosis more cranially than the metatarsophalangeal joint in the foot or the metacarpophalangeal joint in the hand. You can quite easily imagine that if we stick to this definition, you may lose some patients. For this reason, last year new criteria were presented. Indeed, those criteria are associated with a specific score. If you have a total score superior to 9 points, you can classify the patient as having scleroderma. This new scoring system also considers other factors, such as telangiectasia, abnormal capillaroscopy, and pulmonary hypertension. Moreover, we have a number of specific autoantibodies that are found in the disease. So these new criteria are definitely able to classify more patients, especially patients with the diffuse form, inside the correct classification of the disease. So, the ARA criteria are: main criterion is proximal scleroderma, normal bilateral and symmetrical in locations proximal to MCF and MTF. And minor criteria are sclerodactyly, picting scars, and pulmonary fibrosis. We need for diagnosis one main criterion or one main criterion or two minor criteria. But remember that we lose patients with local scleroderma and crest. The sensitivity and specificity of the criteria are much higher than those of the previous ones. We moved from 80 to 95% in sensitivity and 77 to 93% in specificity. In general, the skin-limited form of scleroderma with anti-centromeric antibodies has a good prognosis. However, 10% of patients will develop pulmonary hypertension, which can be dangerous even if we have drugs that can be used specifically to treat pulmonary hypertension, like bosentan, which is a dual endothelin receptor antagonist. When you have pulmonary involvement, the prognosis is significantly worse. Sometimes you may also have malabsorption and primary biliary cirrhosis. The diffuse form has a worse prognosis which clearly depends on the organs involved. If the kidney is involved, the survival at 10 years is just 30%. Okay, here we can see the pathogenesis. So a number of factors have been implicated, but none of them seems to be sufficient for giving rise to the disease. There are a lot of descriptions, some of which I already shared with you when talking about scleroderma fibroblasts. So we have vascular alterations. The regulation of vascular tone is dependent on endothelial and neurogenic control. Vasodilation is mediated by factors produced by endothelium, so nitric oxide and neuropeptides. Vasoconstriction is mediated by endothelin 1. In systemic sclerosis, equilibrium between vasodilation and vasoconstriction is altered towards vasoconstriction. Yes, scleroderma fibroblasts, which are of activated phenotype over production of type 1 collagen and matrix proteins that are glucosaminoglycans, expression of PDGF receptor, and resistance for apoptosis. We have an immune activation, early dermic CD4 positive T cell infiltrate in early phases, and indirect signs of T cell activation in peripheral blood, so high serum levels of soluble IL-2 receptor, high serum level of IL-2. We have autoantibodies production. You can also have environmental factors involved in pathogenesis, especially infectious agents such as retroviruses due to homologies between retroviral sequences and topoisomerase, and insertion of retroviral sequences in fibroblasts has activating function, and also herpes viruses like cytomegaloviruses have been linked to the development of this disease. So I just want to point out three different areas which are strange enough to be discussed about this disease. First is microchimerism. A study highlighted that lymphocytes from the child are able to remain in the mother's body for a long time after pregnancy. In this kind of studies, what you do is to look for lymphocytes in women that have had a boy, so that in the circulation of the mother you can identify lymphocytes bearing the Y chromosome. Apparently, there is a significant number of such lymphocytes in mother with scleroderma. So the hypothesis is fetal cells could attack maternal tissue as in graft versus host disease. In scleroderma patients, the persistence of fetal cells occurs more frequently. The cells are in greater number, and cells are present both in the circulation and skin. So, phenomenon is most easily demonstrated for fetal cells of male origin. Scleroderma mainly in women after childbearing age. Okay. similarities of systemic sclerosis with chronic graft versus host disease. The second model was proposed and published in the New England Journal of Medicine by an Italian group. We tried to demonstrate the presence of antibodies towards the PDGF receptor in scleroderma patients. They showed that those antibodies are present and that PDGF receptor bound by these antibodies gets activated, causing an increased production of collagen by fibroblasts. The funniest thing about that is that although the same group from Ancona is still publishing results on that, apparently this specific experiment could not be replicated in other labs. So there is some skepticism. The last clue came from a study published by an American group from Johns Hopkins this year. This group found out that there is a group of T lymphocytes that seems to be reactive to a mutated gene that could be found in tumors. The hypothesis they worked on and they published on Science, so it's quite robustly demonstrated, is that probably scleroderma can be the other side of the coin of an effective anti-tumoral response. They found out that there is a strong cross-reaction between some autoantigens that may be included in fibroblasts and antigens that may be presented by mutated tumoral cells. They found evidence in a number of patients that they may have had a tumor with this mutation. The immune system response was so effective to clear away the tumor, but it was also so strong to generate the disease by cross-reacting. This is an extremely interesting hypothesis. Clearly, it may not explain all cases of scleroderma, but definitely a significant number of them. This may be the price that the organism is paying for an effective antitumoral response. Indeed, this is in line with the observation that scleroderma-like disease degenerating into chronic graft versus host disease. So when you have an effective lymphocytic autoimmune response generated by T cells. Now let's talk about UCTD and MCTD. So, we have a number of diseases that are a kind of overlap syndromes or undifferentiated syndromes. UCTD, which stands for undifferentiated connective tissue disease, is characterized by the presence of Raynaud's phenomenon, inflammatory polyarthritis that does not meet the criteria for rheumatoid arthritis or other diseases, skin rash resembling those of systemic rheumatic diseases, positive serological studies, single or multiple, and signs of systemic inflammation. There is a possible evolution. You should follow these patients because some of them will just remain like that, while a number of them will develop an overt connective tissue disease. 93% of patients with UCTD and anti-CCP plus citrullineated C-peptide positive test will develop rheumatoid arthritis, whereas among anti-CCP negative patients, only 25% will develop rheumatoid arthritis. We have also a number of overlap syndromes. One of the best characterized is the overlap between rheumatoid arthritis and lupus, also known as lupus, in which the patients have criteria for both of the diseases. One of the interesting overlap syndromes, as it is rather diffused, is the mixed connective tissue disease. It's an overlap of systemic lupus erythematosus, scleroderma, polymyositis, and rheumatoid arthritis. So patients may have different manifestations, but typically they are milder than what you expect in the single disorder. Also, you usually don't have CNS or renal disease. You may also as well have a form of arthritis that is more serious than what you may find in patients with lupus, but certainly is less severe than what you find in rheumatoid arthritis patients. You may have pulmonary hypertension and pulmonary fibrosis, and typically you have the anti-U1 RMP protein antibody. And in the image you can read the criteria for diagnosis. We have we have serological criterion, which is anti-RNMP with more than 1 over 1600 titer. We have clinical criteria, which are angioedema, synovitis, myositis, clinically or histologically compatible with polymyositis, Raynaud's phenomenon, atherosclerosis, with or without proximal skin sclerosis. For diagnosis, we need serological criterion plus at least 3 clinical criteria, at least one among synovitis or myositis required. And this is for mixed connective tissue disease.